I would like to invite Dr. Piazza to continue with the title of Rivaroxaban for coronary artery disease. What patient might be eligible?
Excellent, thank you so much. It's a pleasure to participate in this rapid-fire session. Luckily, a lot of groundwork has been laid down by my colleagues so far, so should be easier for me. So we're going to talk about Rivaroxaban for coronary artery disease and hopefully arrive at a point where we can figure out which patients might be eligible. If we look at the pantheon of trials that have gone on for the last 2 decades focused on reducing cardiovascular events in patients with coronary artery disease, they've largely focused on intensifying antiplatelet therapy. And although the increased intensity of antiplatelet therapy does correlate with a reduction in cardiovascular events in some trials, albeit modest, there is also an increase in major bleeding and in some cases substantial. Our understanding of the pathophysiology of atherothrombosis, and this is a beautiful figure by my colleagues Dr. Banaka and Dr. Krieger, our understanding of atherothrombosis really suggests that the pathophysiology is really not limited to just the platelet, and so we couldn't expect that intensifying antiplatelet therapy would be the sole way of actually reducing this burden of cardiovascular events. Indeed, we know that thrombin is a potent stimulant of platelet activation and also leads to cross-linked fibrin clot. And these two processes lead to thrombosis, and perhaps interacting with both of them will achieve better efficacy. The first trial to really wholesale look at this idea of hybrid therapy, I think we could consider to be Atlas ACS2 TIMI 51. This was a study of patients with acute coronary syndromes who were on aspirin. They were also largely on a thienopyridine, mostly clopidogrel, and were randomized to either placebo, a low-intensity antithrombotic regimen of Rivaroxaban 2.5 milligrams twice daily, or a higher-intensity regimen of Rivaroxaban 5 milligrams twice daily. And here we can see there was a special observation in the Rivaroxaban 2.5 milligram twice daily regimen with reductions in cardiovascular death, MI, and stroke, overall cardiovascular death, and all-cause mortality. And this came with a very reasonable rate of bleeding compared with the other groups. This was then subsequently evaluated in stable cardiovascular disease in a trial that has received its fair share, well-earned, of course, of discussion, the COMPASS trial. This was a study where patients with stable cardiovascular disease were randomized again to this combination, this hybrid therapy of Rivaroxaban 2.5 milligrams twice daily and a low-dose aspirin versus a more robust antithrombotic regimen of Rivaroxaban 5 milligrams twice daily versus aspirin 100 milligrams once daily. And here we can see reductions in composite endpoint of cardiovascular events, including death, stroke, and MI, with particular strength of efficacy seen in this hybrid group of Rivaroxaban and aspirin. If we look at coronary artery disease patients specifically, again, we see that this hybrid approach that speaks to a dual pathophysiology provided the greatest efficacy at reducing events. There was an increased risk of major bleeding, similar to what was seen with the higher dose of Rivaroxaban, but overall a manageable risk. Looking at patients with peripheral artery disease in this sub-analysis of COMPASS, we see that the PAD patients achieve a very similar benefit when it comes to major cardiovascular events, major limb events, a combination of major cardiovascular and limb events, and don't seem to be at an increased hazard of major bleeding compared with the overall trial population. Now, we already saw some of this data from Scott about dual versus triple therapy, but if we look at meta-analysis in patients with AF who also have coronary artery disease, we can see that a hybrid approach with low-intensity regimens or a low-intensity combination combination seems to work better than triple therapy when it comes to safety without a loss of efficacy. So rolling this all together, who's going to be eligible for this regimen when it becomes available? Likely patients with polyvascular disease and a non-high bleeding risk, patients with stable CAD or PAD at increased risk of cardiovascular events, and again, a non-high bleeding risk. And then we're awaiting Voyager's results, but potentially patients after PCI or peripheral intervention. Thank you.